I'm Brett Klein with Eisenhower Health here in the Public Relations and Marketing Department. Welcome. And I will be your moderator as we go through. So please use the, we are recording and we are live. And so currently I'm muting everyone as you enter so that the physician can speak freely, and then we'll record that. And then please use the chat feature within Zoom and to ask any questions, any comments, and what we'll do is we'll either pause and ask a question if it seems appropriate, or most of them will be held until the end, and we'll do a live Q&A with the doctor, and I'll turn off the recording at that time. This will be posted on the Eisenhower Health website within the next 2 weeks. It'll also be on our Eisenhower Health YouTube channel. So if you've not checked out either of those, we have dedicated pages for orthopedics, for cardiology, for cancer, for a multitude of specialty areas. And you'll find a lot of our past lectures up until even last week already online and up for you to view. So with that in mind, I'm going to turn it over to Dr. Schnaser, who is going to give his update, and we're going to talk about outpatient hip and knee replacement surgery, a paradigm shift, and he will tell you what that means and how we're moving forward in our new future of orthopedics. Welcome, Dr. Schnaser, and you're live.
All right, excellent. Can you hear me okay?
We can.
Excellent. So thanks for joining me today on this nice Tuesday afternoon. I'm going to talk to you about something that has absolutely, I will tell you, been a terrifying experience for me to go through over the last 5 years. Not because it doesn't work well, it's just something that when people started doing hip and knee replacements 40, 50 years ago, they used to stay in the hospital for 3-4 weeks. And now we're being expected to send people home the same day. So I know a lot of people, there's a lot of anxiety over this sort of thing, but truthfully, it's actually been a very, very nice thing for most patients. And I think if you talk to most people that have this pathway, they'll tell you that it was a much preferred pathway than staying in the hospital. So a little bit about me. I'm a diehard Trojan. It's where I went to undergrad. I met my wife at USC. I do have clinical privileges at Loma Linda. I spend time up there with the residents and the fellows quite frequently. I'm one of 2 reconstructive surgeons up there as well. So I just like living in the desert a little bit better. So the majority of my time's out here. Eisenhower is a phenomenal place to practice. We're very well supportive. I'm currently the outgoing chief of orthopedics. I'm the incoming chief of surgery. So there's a lot of programs that I am involved with here at Eisenhower. It's been a great place to be. To kind of to sort of toot Eisenhower's horn, we're not the only ones that feel that this has been a very nice place to be, but we've won national accolades over this. It's a Joint Commission Center of Excellence for hip and knee replacements. We're ranked in U.S. News and World Report. We've been ranked by CMS. We've had a 5-star rating with CMS. And you get these over quality programs, and focusing on quality is a very, very important thing. Since I've gotten here, we've really tried to build a program based on quality and patient satisfaction. And it's really turned out to be a very good program and experience for most people that have to go through a hip or knee replacement. And it's had a lot of rippling effects throughout the health system. And I think it's been a very good thing. So our joint replacement program, basically, we want to provide exceptional and comprehensive care to people undergoing hip and knee replacements. So we try and really get people through the preoperative process, the surgery, and the postoperative process. as easily and as smoothly as possible. There's always bumps in the road that can come up when we do these sorts of things. These are very anxiety-provoking procedures for people to go through, and we try and make it a very easy and comfortable experience for most people that go through this. We've really worked hard in providing a quality program, and I will tell you, it's not the easiest place in the world to do this sort of thing. This is what it really takes to do a multidisciplinary joint replacement program. As you can see, it's not just the doctor and the hospital. It really takes a village to build programs like this. And Eisenhower's been very, very supportive. Every little thing that we do or we want to change or we want to improve through takes a process to go through. It's not like a lot of these changes can occur overnight in some cases. So it's been a very, very, it's very complex. We have meetings regularly, twice a month, to talk about how we can make these experiences better. So this is the question. I will tell you, well, why do you want to go home the same day? Well, and we'll go through the history a little bit, but it really was taken off as an option for most patients for CMS to stay in the hospital for 3 or 4 days. And this is the Center for Medicare Services. They basically said, hey, these patients, they don't have to stay in the hospital overnight, and we're not going to pay for an overnight stay. So we want you to figure out how to send them home the same day. And this is obviously flowed through to a lot of the private insurances as well. So this is something that's really been driven by the payers and not necessarily the physicians. I will tell you, like I said, this has been a terrifying experience for us when we start going through this, because there are a lot of barriers to safely get people home the same day. But truthfully, once we've worked a lot of these things out, it's really become the preferred method for most people when they have their joint replacement to go home the same day. There's a lot of benefits. We're seeing people are happier. Even just small things like sleeping in your own bed, people sleep better. Hospitals, the way we really want people to look at them is that they're for sick people. When you come in for an elective hip or knee replacement, you're not sick. We want you to go home where things are more comfortable for you. So what is CMS? For those of you that don't know, it's the Center for Medicare and Medicaid Services. Essentially, they pay the bills. They pay the majority of the bills. They pay the hospital bills. They pay the bills at ambulatory surgery centers, and they pay the doctors. Obviously, there are co-pays that go along with that with the patients, but they're the ones that decide how we essentially practice medicine. And a lot of private insurance companies and HMOs really follow CMS's guidance for what they decide to do for people. So in January 1st, 2018, CMS took total knee replacements off the inpatient only list. So what does that mean? That means that people who have their knee replacements can go home the same day. And Medicare basically said that they're only going to pay for an outpatient procedure. So there's a strong difference between people who have their knees replaced historically and who have stayed in the hospital for 2 or 3 days, and people who go home the same day. And that difference is how much Medicare is willing to pay for it. So when things come off the inpatient only list, it means Medicare is cutting their reimbursement significantly because they're not going to pay for a hospital stay. And that's exactly what happens. Now, along with those, when things come off the inpatient only list, it means you can have your surgery in an ambulatory surgery center. So an ambulatory surgery center is a freestanding surgery center, typically not connected to the hospital. So the total knees were the first ones to come off the inpatient only list. And in January 1st of 2020, total hips came off the inpatient only list. And again, both hip and knee replacements that are straightforward hip and knee replacements can be done in ambulatory surgery centers or an outpatient surgery center. An outpatient surgery center is usually owned by a hospital. We have one here at DOC, and it basically means that it's not an inpatient surgery center. It's where outpatient surgery is done. So why was this done? Well, it all comes down to money when it comes to payers. There are several surgeons who did a lot of private pay commercial insurance patients in ambulatory surgery centers. Why would they do them? Because it's ultimately less expensive for the provider. They lobbied Medicare and Congress that basically these things could be done safely and effectively in ambulatory surgery centers and outpatient surgery centers, and they didn't need to be on the inpatient only list. Along those lines, a lot of things have essentially come off the inpatient only list in the last 2 or 3 years. Medicare spends a lot of money on inpatient surgery, and they're really taking a lot of things out off the inpatient surgery list. I think something like 250 procedures in the last year have come off the inpatient only list. And what made them decide to do this? So there's a lot of data that was generated showing that it was actually a very safe thing to do for patients to send them home the same day if it was done safely. And we've spent a lot of time, effort, and energy making sure that we do this safely for patients. So I like to think of our program as three different phases. There's the preoperative phase, there's the treatment phase, which is usually the surgery, and there's a recovery phase. So I'm going to go through each of these phases independently. So when people go home the same day, either for hip or knee, and now a lot of spine procedures, a lot of foot and ankle procedures that were traditionally inpatient surgeries, we call patients in this program the fast track program. So again, it's 3 different phases: preoperative phase, surgery, and the postoperative phase. So the preoperative phase typically is when you come in to see us in the office and we indicate that surgery needs to be done, whether you have a hip replacement or a knee replacement. And this is done either by the physician or their physician assistant who does this. A physician assistant are an integral part of the treatment team with hip and knee replacements. Often when you come see myself or one of my partners, instead of waiting for us, the physician assistants are well qualified to indicate most surgery. Not all, but most. When you come in and see us, what we do is we place an order for surgery, and that's done on our end. It goes to our surgery schedulers. Now, before our surgery schedulers can see you or can give you a surgery date, we have to get insurance approval. Shocking that insurance runs the world and we can't do anything without her approval. And Eisenhower basically won't let us give people dates until they have insurance approved, because they won't let us do surgery without the guarantees that things are going to be paid for, which is reasonable. You know, Eisenhower primarily takes care of the Medicare population. 60 to 70% of the patients here are Medicare. And there's not a lot of margin for error for them. So for them to continue to offer the programs that they do, we have to make sure that the hospital is going to be taken care of. What happens also during the preoperative phase is the medical clearances need to be done. So when we initially did this, it was only the healthiest of the healthy people were going to go home the same day. We really wanted to test out the program. And over the last 4 or so years, we've gotten a lot more lax. We've understood a lot more of who does well and who can go home the same day. So a lot of times we need medical clearance before we get your surgery. So this is either obtained from your primary care doctor or your one of your other specialists. If you have a lot of medical comorbidities, such as a history of heart issues, the cardiologist will clear you, and we cannot schedule your case until we have cardiac clearance. We can schedule your case if we're waiting on medical clearance, but cardiac clearance is a hard stop. We really need to get that done. Most of the surgery that I do is robotic, so that does require a CT scan, and that's a whole other topic, but that will also be done in the preoperative time period. It has to be done within 3 months of your surgery for it to be an accurate scan. The preoperative phase consists of a total joint class. So during the ages of COVID, we've had to develop a virtual option where you can watch it on an iPad. normally, we have a live class where it's taught by our nurse practitioners, and a lot of questions can be answered in those classes. But when COVID surges, we tend to really limit the inpatient or in-person classes for obvious reasons. You're assigned a nurse navigator. So we have nurse navigators that help our joint replacement patients sort of coordinate what happens after surgery. We help things like your home health, which is nursing and physical therapy that will come to your home afterwards. We have to get that authorized in advance, and we help pick a company that usually coordinates with your insurance company. That's really what the job of the nurse navigator does, is they help coordinate a lot of your postoperative care. And then there's a pre-admission testing side of things where we get a chest x-ray and EKG, several regular labs that are needed for surgery to make sure that there's nothing outlying or something that's abnormal that would make surgery non-safe. And this has to be done within 30 days of surgery. My office, we always do. So for people who are fast track, we do a preoperative visit with one of my PAs. What we do at that time is we give you all your prescriptions. So you have them when you go home the same day. You don't have to stop by the drugstore. This is a very important thing to pick up before your surgery. That way you're not trying to wait on things like insurance authorization. As you can tell, I talk a lot about insurance, and it really makes our life miserable dealing with insurance companies and getting authorizations for every single thing that we do. But it is what it is, and we try and make it as painless as we can for you. And this is usually done mostly by our office and our surgery schedulers. We go over any last minute questions that you have. The preoperative visits usually within the first 1 or 2 weeks prior to your surgery. We review all the data from the labs that were done at your pre-admission testing appointment. We have you get your walker. We talk to you about other needs. There are things like ice machines if you want to arrange for an on-cue ball, which we'll talk about in a little while, or iovera. We can make those arrangements in these visits as well. A lot of questions come up about postoperative pain medications. So we have a multimodal pain management approach. So I think narcotics are poison. I really think that they're a necessary evil after a joint replacement, especially a knee replacement. But we really want you to limit your narcotic, and as a result, we give you a couple of different medications and treatment modalities to sort of limit this. So there's several different kinds of narcotics. They all work very similarly. There's Percocet, there's Norco, and then there's Tramadol, which is a sort of a light narcotic. Narcotics can make you very nauseous, and they can cause things like constipation. So we usually give you a stool softener as well. And then we combine this with an anti-inflammatory, such as Celebrex, prescription strength ibuprofen, as well as something like a neuromodulating agent. So Lyrica and Neurontin are used to help sort of deaden the nerves around your surgical incision, which help reduce pain and pain overall. Then there are other treatment modalities that we use. We use cold therapy, which we'll talk about. I'm a big believer in using CBD ointment, drops or whatnot. Patients get a lot of relief with this, and more or less, it's probably safer than most of the narcotics that we use. Then there are things like the on-cue ball, which I'll talk about, and iovera, which are also options. So cold therapy, it's exactly what it is. It's essentially icing the knee or hip after surgery. So there's nothing wrong with a regular bag of frozen ice. They can be messy, they can have other issues, but at the end of the day, cold therapy is cold therapy. When you use standard ice or ice packs, it can burn your skin, so you have to really watch what you're doing. And you can only leave it on for a very short period of time. You don't want to leave this on your skin for more than about 20 minutes. So what we've come up with is that Bragg, and there are other machines out there, but Bragg has these ice packs that work very well. I will tell you that out of everything, this is the number one thing that people really seem to rave about. It is something that you have to purchase. They're about $350. But this is something that we get wonderful feedback for. Obviously, this is optional, but it's something that people rave about. The big thing with these ice machines that we offer is that they add compression to the knee or the hip, and you can leave them on for longer than 20 minutes. You can leave these things on all night long without the risk to your skin and freezing something and causing irreversible damage. Ice and cold therapy and hot packs, they can burn your skin quite significantly, and you can have a lot of issues with that. This is avoided with these types of things. And obviously, insurance companies won't pay for them. This is another thing that insurance companies won't pay for, but this is something a lot of patients really asked for. So we brought it in. What it is, it's called an on-cue ball. So that ball there is full of ropivacaine, which is like the numbing medication that you get at a dentist that numbs your knee. It's placed, there's a small catheter that's placed in your thigh at the time of your surgery. And what this does is that this slowly injects numbing medication around your knee and really helps significantly reduce the amount of pain that you have after surgery. So again, this is something that patients have asked for. It's something that does add cost. It's an out-of-patient pocket cost that goes to the pharmacy that supplies them. Eisenhower does not have, what happens in the state of California is they require an outpatient prescribing license for Eisenhower to give people medications to go home with, and they do not have that. So this is supplied by a third-party pharmacy that we make arrangements before your surgery. This is placed, the catheter is placed at the time of surgery, and this gets hooked up when you go home the same day. We didn't know how well this worked, so we surveyed the first 20 patients that got them, and 19 out of 20 people felt that this made a significant difference in their postoperative pain, so we continue to offer it. It costs about $350, and this goes to the outpatient pharmacy. This is something new that we started doing a couple of months ago here. It's really only for knee surgery, and the same thing's true with the iovera. Is that what this is cryotherapy. What it does is you have this little wand, and it goes in and it basically freezes all the little nerves around the knee. So the whole idea here is to really reduce the amount of pain that you have after surgery. So this is something insurance companies and Medicare do not pay for. It's an added cost. It has to be done within usually 1 week prior or longer before your surgery. And it's exactly what it is. You come in, and just like the little picture on the right shows, this wand is used. It's got 2 little needles at the end of it. It goes in, and it basically freezes the nerves around your knee. And we've done probably 20, 25 of these. We just started doing this in the fall. And the patients who have had them, they absolutely seem to use less narcotic. And that's the name of the game for us, is to really get people off their narcotics quicker. It doesn't mean you're not going to need the oral pain medications, but these things seem to really make a big difference in how people recover. Again, these are all optional things. A lot of people can't tolerate narcotics. So this is a good option if you can't tolerate narcotics or you just don't want to do them and you want to try one of these things that seem to make a difference. So this has to be done in the office. I preferentially greater than a week before, within 1 to 2 weeks of your procedure. What it consists of is that we take a little tiny needle and we fill it full of a bunch of local anesthetic, and we go around your knee in a big circular pattern where all the genicular nerves, the sensory nerves are. So you can see down in the picture, there's a little brown area where the different points of the genicular nerves, and you basically go around in a circular fashion with the iovera, and you freeze those nerves. And it has an effect of about 3 months in terms of deadening those nerves. And then they usually come back to, they wake up well after you're through your recovery and over the big parts of your pain hump. The iovera, the difference between this and the iovera lasts for about 72 hours. Once the local anesthetic is done infusing into your knee, which is usually 3 to 4 days after surgery, that iovera is discontinued and we have to take the catheter out. So this is kind of an evolution of pain management techniques. And you can do all of them. You can do ice, you can do the iovera, you can do the on-cue if that's something that you really want to do. Again, none of this is necessary, but these things do help, and they do seem to really significantly impact the amount of pain people are in after surgery. So surgery itself, you come in, what happens is you're called the day before for your surgery date. We try and get everyone who's going home the same day done in the morning, so they have an adequate time to recover. What our data shows is from the time you come into the hospital is to the time you go home, the average length of stay in the hospital is about 8 hours. So when you come in 2 hours prior to your procedure, you have your procedure, and then from the time you go home, the whole event lasts about 8 hours. So in the pre-op area, the surgeon, such as myself, will see you, we'll mark your knee, we'll answer any last questions, we sign your consents. We mark the limb, you get consent for the block. So what happens at the time, regardless of whether or not you want to do the on-cue or the iovera, all the patients get a block. So the anesthesiologist comes in after you've either gotten your spinal anesthetic or your general anesthetic, and they do a nerve block on you. And those nerve blocks usually last for about 24 hours. You have your surgery. The majority of patients, about 95% of the patients, get a spinal anesthetic. A lot of people have questions about past spine surgery or bad spines. You're still a candidate for a spinal anesthetic. It's a short-acting spinal anesthetic where it basically numbs your legs for anywhere between 3 and 6 hours. Just so you don't really know what's going on in the operating room, they give you a very light sedation in addition to this, but usually no tubes go down your throat. It just puts you off to a general sleep so you can lie in comfort and not worry about what's going on in the operating room. So I do all my blocks after the procedure is completed. You're usually either in the operating room or in the recovery area. The spinal is usually going on, or you're heavily sedated to where you don't feel the blocks. I try and have people come in and out with very little trauma, and it seems like this has worked very well. So the people who don't do well with fast tracks, it almost always has to do with low blood pressure, which can occur as a result of the spinal anesthetic. So what happens when you get these spinal anesthetics, your blood vessels kind of open up and it causes all your blood to go into your lower extremities. And that can take several hours for that to totally recover. So the majority of people who don't go home the same day, it usually has to do with what we call hypotension or low blood pressure in the recovery area. And it's just not safe to get you up with therapy. So in order for you to go home, we have basically 4 different goals that you have to hit. Your pain has to be well controlled. So with the blocks and all the other things that we've talked about, we do a pretty good job controlling your pain. You have to be able to tolerate a diet. So we want you to be able to go home and tolerate eating food. You have to go to the bathroom. We want everyone going number 1 before they go. And we have to get you to pass physical therapy. The number 1 barrier that keeps you from going home is low blood pressure, because people who have low blood pressure, as soon as we get you up with physical therapy, you feel a little lightheaded, and it can make it very hard for you to get home. So usually about 5% of the patients who are planned on going home the same day do have this problem. It's a very, very, very low number of people. We call it a failure to launch. And that's almost always due to low blood pressure. So this is a patient that I did actually the first year we were doing the fast track program. He's 2 hours after surgery. He's getting around with his walker. He's got his little on-cue ball hanging off of him. That's what that black strap is with the little baggie on it. This is the walker that he picked up before surgery. And this is about the mobility that you expect. We're not expecting people to run marathons. What we expect is for you to be able to safely get up and move around before we send you home. You're not going to win any land speed records typically, but this is about what the level of mobility you can expect is. So for us to also safely discharge you, we can't send you home in an Uber or a taxi. You have to have someone to pick you up there. And then we give you all your instructions with regard to things like your dressings and how to take all your postoperative medications if it wasn't gone through. We try and go through things multiple times so you hear it. So the point of the class, the pre-op visit with the PAT clinic, the pre-op visit with one of our PAs, it's all to keep going over the postoperative regimen so it's clear. Repetition really makes a difference. So the postoperative phase has to do with things like home therapy. So not everyone needs home therapy. You can do outpatient physical therapy in a center. With hip replacements, if you want to do your own therapy regimen on your own, you certainly can. We have a joint replacement book. It shows you all the therapy that you want to do. It's very valid and it's worked very well for people to do therapy on their own. You can give it a try, and if you're just not progressing as well as you want, we can always get you into more therapy. I encourage all my patients to shower. I use a waterproof dressing. You'll feel better if you shower. We don't want you totally submerging the wound, but we want people showering. Usually the dressing care for my patients, it's a waterproof dressing. You take the first layer off after a week, and then under that layer is steri strips. You take the steri strips off after that. And typically there are no sutures to remove. Now with the robotic knees, there's usually 2 little nylon sutures where the satellite dish was attached to your leg. Those come out within 3 weeks of your surgery. And, when do you stop therapy? This question comes up all the time. You can stop therapy when you feel that you are strong enough to do the exercises on your own. You come in, and if you feel like it's a very low valuable asset for you and you're doing things on your own, there's absolutely no reason for you to go to therapy. If you feel that your range of motion's coming along with your knee and you're doing everything as to be expected and the therapy is kind of a waste of time, don't go. And the other side of things, sometimes therapy can be a little too aggressive and it's not healthy for you, especially with the knee. If you go to therapy and if you're in bed for 2 days after therapy, what we want therapy to do is really work on your mobility and your range of motion in your hip and knee after your hip and knee replacement. And it's not really about necessarily strength training, as that can really be a very difficult thing. And sometimes therapy can really overdo it. So that's a discussion to have with your surgeon in your postoperative visit. So, I always have these discussions with people, or at least try and have these discussions with people. A lot of people, when they come in to see me, I usually see people 3 weeks after knees and 6 weeks after hip. They don't really need a lot more. If people are having a harder time on their range of motion, then we'll be more aggressive with their therapy with regard to the knee. But it's very well accepted in the orthopedic community. If you do a good self-directed home physical therapy program, your outcomes can be just as good as someone that's in a very formal physical therapy program. And a question always comes up, when can we return to normal activity? Well, you don't want to compare yourself to your neighbor who said they were golfing a week after their hip replacement. Everyone's different. Everyone has different exercise and pain tolerances. You can't compare yourself to your neighbor. So, you kind of take things on your own accord. When do you get rid of the walker? It's when you feel safe to get rid of the walker. You don't get rid of the walker just because you feel like you need to, because if you get rid of those things too quickly, it puts you at risk for falling after your surgery. Now, people often say, well, I still feel that I should stay in the hospital a night or two. There's really no reason to stay in the hospital. Most of the problems that we actually have after surgery are from patients who stay in the hospital. And what we do is we do a screening process. So people who have significant medical problems, people who have very, very deconditioned Their overall physical ability is very deconditioned and they're not going to do well going home the same day. We can justify keeping some patients as inpatients. We just can't do it for everyone. And Medicare is very, very clear with that. Common concerns in the postoperative period, people often compare themselves to their neighbors. Well, my neighbor had their knee replaced and they said that it was fine and I didn't have any pain. I'm having pain. What's wrong? Well, here's what I can tell you about that. I've watched my wife have 3 babies. When you hear her talk about it, it's no big deal. I will tell you, I was there. It was a big deal. They hurt. These things always hurt. People tend to have selective memory about what they go through. Some people may be preconditioned to pain if you've taken a lot of narcotics in your past. That can make you more sensitive to pain. Narcotics are bad actors in a lot of ways. People generally, when they get off the narcotics, they actually start feeling better. When do you get off your walker? Like I said before, it's when you want to get off of your walker. I would say the number one thing that people persistently really have an issue with after their surgery that can last months is issues at sleeping. So sleep discomfort, and it manifests in a lot of different ways. Some people feel that they have restless leg. People have significant night pain. People are just very stimulated and they just can't fall asleep. That's a very common problem after a hip or knee replacement. Sometimes the opiates themselves can be stimulants, and that can be, you think that that's not correct, but actually they can be stimulating as well. A lot of people, they are sedating, but in certain people they can be stimulants, so they can be keeping you up. And people just have an issue with sleep. It usually takes about 3 to 4 months for that to totally resolve. The other big thing is fatigue. Fatigue and sleep issues kind of go hand in hand. When you're not sleeping, you're going to feel tired. So those things usually go away by around month 3 or 4. And that's regardless if you stay in the hospital or you go home the same day. People seem to be recovering faster, without a doubt, when they go home the same day. And multiple studies have shown that the longer you stay in the hospital, the harder and more dependent you are on things like opiates after surgery. People who go home the same day, they report much higher patient satisfaction scores. In general, they use less narcotic. And overall, they get back to their normal day-to-day life quicker. And that's seen on whether or not you even stay in the hospital a day or 5 days. The longer you stay in the hospital, the prognosis for a quick recovery starts to diminish. And you start to see that really only after one night, believe it or not. So postoperative swelling, this is a very normal thing. People often ask, wow, it's 3 weeks after my knee replacement. Why am I still swollen? A lot of people have this swelling that lasts for months. It usually goes away. Occasionally, it can be related to varicose veins if you've already had varicose veins and you have knee surgery, can make your varicose veins worse. What we recommend people to do if you're having a lot of issues with swelling is to use compression stockings if you can use them. Not everyone can put them on, and they're very difficult to put on, but elevation also works significantly well for reducing the amount of swelling you have. It almost always resolves one way or the other. Occasionally, if you've got a predisposition for varicose veins, you may need a vein stripping procedure done by the vascular surgeons. And all I can tell you, it's kind of the price of admission for having your hip or knee replaced. Pretty much anyone that has surgery on their hip or knee have some element of swelling, some worse than others. So here are our program statistics. So, over the last 3 fiscal years, and 2022 actually our fiscal year started in July. But you can see that we are really growing the volumes here, and it speaks a lot to the quality programs that we've built and the surgeons that we've brought in. So we're probably on pace to do close to 2,000 hip and knee replacements this year. And this is the volume that we do per month. Obviously, it's very busy. We're one of the top 3 hospitals in California in terms of our monthly volumes. If you look at a place like Hoag, they may do more joint replacements in general, but they're spread out over multiple locations. This is distinctly just at Eisenhower, and Eisenhower has given us a significant amount of resources to make this a safe and effective program. We have a lot of resources that cost the hospital a lot of money, and it's to deliver a very safe and effective product. So here's our joint replacement. So the the green bar is our fast track patients. The yellow bar are the people who would stay in the nursing home or stay in the hospital for 1 or 2 midnight, or for 2 or more midnights. And the orange bar is the people who stay overnight. So that's called outpatient in bed. The hospital really won't let us just keep people overnight because they get paid the same. What happens if we keep someone overnight and they don't qualify for an inpatient stay, the hospital actually loses money on the patients. And, you know, they have to be able to be somewhat profitable to make this work. You know, and again, I hate talking about it, but this is just the facts of life. So you can see in 2020, we weren't doing a huge volume of patients where we were sending them home. We were being a lot more conservative. Well, as COVID ramped up, a lot of people were suffering and there's no way they wanted to stay in the hospital. So a lot more people were interested in going home the same day. So it wasn't nearly as tough a sell for patients. You know, a lot of people would come in and initially, and they're like, well, my friend went to a nursing home for 3 weeks. Well, COVID's really changed that ball. And what we've seen is that more and more people are going home the same day. We're not seeing any difference in things like 30-day readmission rates between the people who go home the same day and the people who stay in the hospital. We actually see higher patient satisfaction scores and the people who go home the same day. And that program's really taken off. And you can see in 2022, we're slated to really, really outperform the inpatient stays significantly more than the outpatient. We estimate we're going to be doing about 60 to 70% of the joint replacements where people will go home the same day. Again, the reasons why we keep people overnight or we admit them to the hospital is because they have a lot of medical comorbidities that it really just isn't safe and they need to be monitored. People with significant cardiac histories, people with really out of control diabetes, people who have a variety of pain management issues where sending them home is just not going to be a good thing. Unfortunately, Medicare doesn't really care, and CMS and the private insurance companies, you know, us trying to make the case that you don't have anyone at home to help you, they don't really care too much about that. If you don't have a lot of support, the feeling from Washington and CMS is that you can always find someone that can come check on you once a day. So that's not something that has really been very popular in us. You know, we just can't say, well, this nice person doesn't have anyone to help them at home. That doesn't matter to the payers. So we have to find someone, or you really have to get some support, or even a neighbor to help you through this process. And truthfully, you know, when you go home, you do better. When you go home, you're forced to get up and you're forced to make yourself dinner. You're forced to go to the bathroom. It's all part of the recovery. And this is why people recover quicker. When you're in the hospital and you go to skilled nursing facilities, you become more reliant on the hospital help to get you out of bed, to get you to the bathroom. You rely on them to get you food, and it can really slow your recovery, believe it or not. So here's what we're seeing over the last several years. You can see here, these are our quality metrics. So when we first started this cycle, our average length of stay for people was 2 days. We've really cut that down. And this is all comers and people who have inpatient and outpatient surgery. The reason why this has come down to 1.18 days, which for a primary Medicare population is phenomenal, is that most people are going home the same day. So the people who end up staying in the hospital, they end up staying for 5 or 6 days for a variety of reasons. That really swings up the average. If we could just limit it to people who stayed 2 midnights, we would be well below a day in recovery. Unfortunately, in the last 2 years, we've had 2 deaths. You know, that's not something that we ever want to talk about, but it is a fact of life. You know, these are not benign procedures to do. Both both of those occurred in patients who ended up staying in the hospital. So we appropriately screened them. They did not occur in people, and that was within 30 days, people who went home the same day. They occurred with people who went home who were they had a lot of medical issues that contributed to their issues that they had. We have a very low complication rate here. And we have a very low 30-day readmission rate. So the target, we bench this on national averages, what hospitals, what Medicare insurance companies believe where we should be. And as you can see, we really outperform the competition here. Infections come up. So the SSIs is the surgical site infections. They happen at every hospital. The average in the hospital is around 2.5%. We are at 0.28% for the current certification cycle. So, when you consider that we've done several thousand joint replacements in that period, almost 4,000 joint replacements, and we've had 9 surgical site infections, our infection rate is exceedingly low. Now, my partner and I both take care of a lot of infections. Those were not done at the hospital necessarily, but we're a tertiary referral center for this. So we do see infections, but in patients who have had their surgery here, our infection rate is exceedingly low. So Press-Ganey is our patient satisfaction scores. Those are for people, they get those for people. Anything above 80% is well. So these are graded on a scale of 1 to 10 in terms of how people do. They're given to inpatients only, not outpatients. And you can see what happens, the length of stay that people have. As the length of stay in the hospital goes up, the Press-Ganey scores typically go down. And what we're seeing is the people who end up staying in the hospital longer, they become more dissatisfied with the stuff that they do and see. This is not a hotel. It's not the Four Seasons, and part of the reason why people are happier going home is when you're at home and you want to take a pain pill, there's not a nurse telling you that it's not due yet. You take it when you want it. The same thing when you want your food, you get it when you want it. People, when they're in the hospital and they have to wait for things like pain medication, and whatnot, it does drive dissatisfaction rates, but still getting an 88.5 on a Press-Ganey is still very, very good. It's not where we want to be, but we're dealing with other multifactorial issues there. I've got about 15 minutes of questioning.